Welcome back to The Rocket. Let's break down intrauterine growth restriction, or IUGR, a high-yield topic for the USMLE. Definition. IUGR means the estimated fetal weight is below the 10th percentile for gestational age. But not all small babies are pathological. It's pathologic when caused by placental insufficiency, maternal disease like hypertension or diabetes, or fetal anomalies. Now, two major types of IUGR. Symmetric IUGR occurs early in pregnancy. The whole fetus is proportionally small, head and body. Think of chromosomal abnormalities or torch infections like CMV, toxoplasmosis. Asymmetric IUGR occurs later in pregnancy. The head is spared, but the abdomen is small. Classic cause? Uteroplacental insufficiency, like preeclampsia, smoking, or malnutrition. Recognizing the pattern, symmetric versus asymmetric, is key for diagnosis and exam questions. Serious. Let's dive deeper into IUGR, focusing on causes and diagnosis, a guaranteed high-yield area for the USMLE. First, the causes of IUGR. Break it down into maternal, fetal, and placental factors. Maternal causes: hypertension, especially preeclampsia, smoking, alcohol, and drug use, malnutrition, poorly controlled diabetes, autoimmune conditions like SLE and antiphospholipid syndrome. Always ask about these in the vignette. Fetal causes: chromosomal abnormalities like trisomy 18, torch infections, CMV, rubella, toxoplasmosis, herpes, congenital anomalies, multiple gestation, twins competing for nutrients. Placental causes: infarction, thrombosis, or abruption, abnormal cord insertion, placenta previa, cord abnormalities like single umbilical artery. Now, how do we diagnose IUGR? First clue: fundal height lagging behind gestational age. Next step: order an ultrasound. Ultrasound evaluation includes biometry. Look at EFW, AC, HC, and FL. Check amniotic fluid. Oligohydramnios is common. Umbilical artery Doppler. Increased resistance, or absent reversed end diastolic flow, indicates severe IUGR. Middle cerebral artery Doppler, decreased resistance. Brain sparing effect. And don't forget the BPP, biophysical profile, for overall fetal well-being. Mastering this framework helps you tackle any IUGR question they throw your way. Serious. Now let's talk management of IUGR. Step 1. Monitoring. Use serial growth scans to track fetal weight and abdominal circumference. Repeat Doppler studies, especially umbilical artery and MCA. Assess fetal well-being with biophysical profile, the BPP. Always look for a cause. Rule out preeclampsia, autoimmune disease, or placental pathology. So, when do we deliver? If the fetus is term, over 37 weeks, and there's no further growth, plan delivery. If you see worsening Doppler findings, non-reassuring fetal testing, or declining BPP, deliver, regardless of gestational age. If there's severe IUGR and absent or reversed end diastolic flow in the umbilical artery, especially before 34 weeks, give corticosteroids for fetal lung maturity and plan early delivery. It's all about balancing fetal maturity with the risk of staying inside a compromised uterus. Timing is everything. This is how you manage IUGR. The Rocket Way. Let's lock in the high-yield summary for IUFD. Intrauterine fetal demise. A tough but testable topic on the USMLE. Definition. IUFD means fetal death in utero at dash to 20 weeks in the United States, dash to 24 weeks in the United Kingdom. It's confirmed before delivery and always requires thorough evaluation. Now, the causes fall into three main categories. Maternal causes: diabetes mellitus, preeclampsia and chronic hypertension, thrombophilias like antiphospholipid syndrome and SLE. Fetal causes: congenital anomalies, infections, especially parvovirus B19 and CMV. Always think torch if infection is suspected. Placental causes: placental abruption, infarction or thrombosis, cord accidents, including true knots or prolapse. On exams, the clue is usually sudden loss of fetal movement, followed by absence of fetal heart tones on Doppler. Coming up next, diagnosis, management, and high-yield MCQs, only on Medical Rocket. Let's break down the diagnosis, workup, and management of IUFD, a high-yield, emotionally sensitive topic for your USMLE prep. Diagnosis begins with clinical suspicion. Absent fetal movements reported by the mother. No fetal heartbeat on Doppler or non-stress test. But the gold standard is ultrasound, confirming no fetal cardiac activity. Next, the workup. Always aim to find the cause. Fetal autopsy, if consent is given. Placental histopathology, infarction, abruption, infection. Karyotype or genetic testing, rule out chromosomal causes. Maternal labs, CBC, Kleihauer-Betke for fetal maternal hemorrhage, torch serologies, thrombophilia screen, especially if there's a history of prior losses. Management depends on gestational age and maternal stability. For most patients, proceed with induction of labor. Misoprostol or oxytocin is used, depending on cervical status. If early gestation, dilation and evacuation, D&E, may be an option. Always offer psychological support. Grief counseling, bereavement care, and clear communication are vital. And don't forget, counsel about recurrence risk, especially if due to APS, SLE, or uncontrolled diabetes. Close monitoring in future pregnancies is key. Sensitive topic, critical content. This is Medical Rocket. Time for some high-yield MCQs. USMLE, PLAB, MRCP style, covering IUGR and IUFD. Let's test your sharpest clinical instincts. Q1. A 28-year-old woman with preeclampsia is found to have a fetus measuring less than 10th percentile on ultrasound. Umbilical artery Doppler shows absent end diastolic flow. What's the best next step? A. Continue pregnancy with weekly Doppler. B. Immediate cesarean delivery. C. Administer corticosteroids and plan early delivery. D. Repeat ultrasound in 4 weeks. Answer. C. Absent reversed flow equals fetal compromise. Give corticosteroids for lung maturity and prepare for early delivery if under 34 weeks. Q2. What Doppler finding indicates fetal compensation in IUGR? A. Increased resistance in MCA. B. Decreased resistance in MCA. C. Increased resistance in umbilical artery. D. Reversed flow in ductus venosus. Answer. B. That's the brain-sparing effect. The fetus shunts blood to the brain, causing down resistance in MCA. Q3. A woman at 35 weeks reports no fetal movement. Ultrasound confirms no fetal heartbeat. What is the most appropriate initial step? A. Immediate cesarean section. B. Psychological counseling and expectant management. C. Confirm diagnosis with repeat ultrasound. D. Induce labor with misoprostol immediately. Answer. C. Before any intervention, always confirm IUFD with a repeat ultrasound. Q4. What maternal condition is most strongly associated with recurrent IUFD? A. Iron deficiency anemia. B. Antiphospholipid syndrome, APS. C. Type 2 diabetes. D. Asthma. Answer. B. APS is a classic cause of recurrent fetal loss. Know this for boards. Q5. Which of the following Doppler findings is most concerning in IUGR? A. High resistance in uterine arteries. B. Decreased resistance in MCA. C. Absent end diastolic flow in umbilical artery. D. Normal BPP score. Answer. C. This is the most dangerous finding. Signals severe placental insufficiency and imminent fetal compromise.